Okay, so we spent an hour talking about tendons, which is required to speak about ligaments because it provides the foundation for understanding ligaments, because in some ways they're simpler and in some ways they're more complicated. So just like the previous talk, we're going to begin with histology and microanatomy, speak about biomechanics, talk about locations and grading, discuss associated bone bruises and fractures, how ligaments heal, which is better than tendons, and what circumstances do they heal poorly, instability and dislocation, which are two different things, micro-instability, and then a sequelae of either micro or macro instability. Deltoid ligament here, and anterior talofibular ligament here, which is clearly abnormal. Okay, complicated slide, but we'll spend about 3 minutes talking about it. So tendons, as we said earlier this morning, transfer a vector from muscle to bone. Ligaments connect a bone and a bone. No transferring a vector, no intrinsic energy. Difference number one. Collagen makes up 75% of tendons, 85% of tendons, and 75% of ligaments. Pretty similar. Both are 90% type 1 collagen, but ligaments have 10% type 3 collagen. Both have about 2/3 bound water. Tendons are hierarchical. Ligaments are less hierarchical. Ligaments have more unbound water, so they tend to be slightly greater than the black tendons. Tendons get their blood supply from the epo, endo, and peritenoids. Ligaments get their blood supply from an epiligament. But ligaments also get nutrition from the joint. That is a major distinction. Ligaments almost always have synovial fluid on one side. That synovial fluid is full of sugar and protein and provides nutrition to the ligament. So one fundamental difference between tendons and ligaments is ligaments heal better because they have the internal blood supply. Both of them have elastin. Ligaments also have a substance called lubricant that provides lubrication between fascicles. Tendons have tenocytes. Ligaments have fibroblasts. Ligament tears are more common than tendon tears because ligaments are weaker than tendons. However, ligaments have greater healing potential than tendons because they get nutrition from the synovium, so they have greater vascularity. So they're very similar in most ways, but the biggest difference is the blood supply and nutrition, which is more limited in tendons than ligaments, and hence tendons have poorer healing than ligaments. So we built a tendon, let's build a ligament. So we have collagen, and we have collagen. Now what's the difference between these fibers of collagen and the ones in tendons? They're not parallel. Right? The ones in tendons were parallel. These are not parallel. Why are ligament collagen not parallel? Stress. They come from all different directions, right? I can sprain my ankle like this, like that, all different ways. So it's not one specific vector. So this is a second difference. Now they have proteoglycans just like tendons do, and as proteoglycans bound water is in blue. And then the ligaments can change the collagen orientation. So not only are they not parallel to each other, tendons can stretch, ligaments can angle. So when a stress comes on a ligament, it not only stretches, but the fibers can split. So tendons stretch this way, ligaments stretch this way. Third difference. You got that? Now they have cross legs just like tendons. Are these smaller, bigger, or the same size as them? Bigger. And they're bigger because they have more vectors coming in and more variable directions, so they have a greater need for stronger cross legs. And they don't have an endo or an epi or a paratena. They only have one layer, which is an epilayer. That's enough. And then they have fluid on one side. You see the blue fluid on one side? Because usually one side is adjacent to each other. Okay, now I want to talk a little bit about biomechanics and response to stress. So here is response, and here is time. And let's start out with bone, because bone is simple. I exercise, and my bones get bigger, right? Very easy, right? Muscular people have bigger bones. And then sometimes your bones get transiently weakened before they get stronger because the bone has to remodel after the pain. And that's why you get stressed. But that's just for comparison. And here's a bone with a stressor. Now tendons, in response to stress, never get stronger. They always get weaker. The opposite of bone. So they get weaker, they get a little bit of healing, they get weaker, they get a little bit of healing, they get weaker, they get a little bit of healing. We went through that, right? Micro tear, micro tear, micro tear. And they never go back up to the way they were before. Right? Right? Right. And then eventually you're going to get tears, and the earlier tears of those tendons, like the Achilles, in terms of how much micro-injury, the patella is in between, and PTT and rotated cuff are older, and maybe that's because they have ischemia as part of it. And so this is just a biceps tear, just to show you a picture of the monotony. Now ligaments. So ligaments do not have this undulation, right? The tendons have that undulation. Ligaments are relatively straight, and they get a little bit weaker over time, but compared to tendons, not that much weaker. Right? Right. And they don't get that much weaker because they have greater blood supply, greater healing potential, because one side of it is synovial. And that's the difference between how bone responds to injury, how tendons respond to injury, and how ligaments respond to injury. And here is a patient who had an elbow dislocation and has both a medial collateral and lateral ulnar collateral ligament injury. Now, in contradistinction to tendon disorders, that some are from subluxation, right? Some are from ischemia, some are from impingement. Tendon ligament disorders are always traumatic, right? There's no such thing as a non-traumatic ligament disorder. And they occur in younger patients, right? Rotated cuff tears occur in 50s, 60s, and 70s. Ankle sprains occur in teens, 20s, and 30s. Because for a tendon, remember I said, a tendon can hold 10 cars. It's really, really strong. A ligament is much weaker. So it doesn't have to have aging to make it weaken to get an injury. It's not as intrinsically strong. And ligaments will tear at the extreme ends of motion. So a tendon will tear as I'm pulling something. A ligament will tear when my ankle is all the way like this. Not when it's a little bit. It has to be off, not first, but all the way like that. And they are sometimes associated with dislocations and sometimes associated with subluxations and thumb ligament gatekeeper injury. Now, gender and ligament tears. It's related to the size of the osseous space and to hormones. So ligament tears in women correlate to where they are in their menstrual cycle, because ligament tears are associated with increased estrogen. So one would surmise that a pregnant woman is more predisposed to ligament tears because it is an estrogen-related phenomenon. And what does estrogen do? It does a bunch of things, but in terms of collagen and ligaments, anyone know what it does? Contractions, right? So your estrogen levels go up right before delivery to allow your sacroiliac joints to open and your symphysis pubis to open to increase the size of the birth canal so you can have a baby less traumatic. So if it does that at the end of pregnancy, a form first of that is when your estrogen levels peak in your cycle, it stretches those ligaments and then they're predisposed to injury. So not only do women get more ligament injuries than men, they get injuries at specific times of their lives, which I think is pretty interesting. So where do ligaments tear? It depends on the ligament. They can tear at the bone attachments, they can tear at the substance, or they can tear an avulsive piece of bone, right? Those are the three ways they can tear. Most of the time they tear at the attachments. So elbow ligaments tear at the attachments, ankle ligaments tear at the attachments, the MCL and the knee tears at the attachments, the collateral ligaments in the fingers and the thumb tear at their attachments, right? Most ligaments. What ligaments tear within the substance? ACL, right? Well discussed yesterday, right? Middle third, proximal to middle third of the ACL. PCL, right at the genu, right at the bend. So certain ligaments tear. Scapholunate can tear either at its osseous insertion or mid-portion. So certain ligaments tear in their mid-portion. And then certain ligaments avulse pieces of bone, particularly children, right? Avulsion fracture is more common in children, but also ankle injuries, even in adults, more common. It's always more common to sprain a ligament than to avulse a bone. But in the ankle, you will avulse bones relatively frequently. So here's an example of an anterior talifibral ligament tear tearing at its talus insertion. And here's an example of an ACL tear occurring in the body of the ACL. So that's what ligaments are. So ligaments avulse, we already spoke about that. So here is an ACL avulsion. And here is the arcuate sign from collateral ligament avulsion. How do we grade ligament tears? I think this is also superficially discussed yesterday. Superficially discussed it again. Grade 1, microscopic tear, seen with adjacent edema. Grade 2, partial tear. So you'll see fluid rather than edema adjacent to it. Grade 3, complete tearing somewhere in the ligament. Doesn't have to be the continuity. And then you'll see a morphologic disruption in the ligament. Now, some of these, the ligaments, the grades don't work. So I'll disagree a little bit. ACL and PCLs don't get grade 1 tears in my experience. They get grade 2 or grade 3 tears. Now, it could be we're missing the grade 1 tears, or it could be they just don't come to imaging, but I don't think you get grade 1 tears. Scapholunate and lunotrapezial ligaments get grade 2 and grade 3. They don't get grade 1 tears. So this is a general rule, but not an absolute rule. So if you look here, we see edema around the fibula, not fluid. So when you see edema, it's a grade 1 tear. So here's an example of all 3 grades. Grade 1 MCL with edema adjacent to it. Can you see the edema? Grade 2 with fluid adjacent to it. You see it's different in signal, but morphologically intact. Grade 3 fluid, but not morphologically intact. That's the classic grading system. Probably works for 90%, but not 100% of ligaments. So here we see an anterior talifibral ligament tear off of the talus. And this will be a grade 3 or complete tear. The vast majority that we image, and again, a grade 3 tear off of the talus. A partial ACL tear. Now, bone bruises with ligament tears depends on the ligaments. So very common, I would say, almost invariable with ACL tears. Almost invariable with lateral ankle tears. Less common, but still very frequent with MCL tears in the knee. Very infrequent with either MCL or LUCL tears in the elbow. And almost unheard of with scapulohumeral and lumbago crucial ligaments. So the presence, size, and frequency of bone bruises varies a lot with the ligament. Now, part of that variability has to do with how quick we do imaging. And with ACL tears, we do imaging right away. But with elbow ligament injuries, we don't tend to do imaging until later in the course of the disease. And in wrist ligament injuries, we almost never do them unless it's very, very late in the course of the disease. But it's important to know that if you have a bone bruise, you have a greater chance of long-term instability and a greater chance of premature osteoarthritis. So it's not only a way to identify a ligament tear when you're less sure or less confident, it's a way of prognosticating or predicting outcome. Now, we said this in the marrow talk. Remember that microavulsive bone bruises are always smaller than compressive bone bruises. So a lateral ankle sprain, the compressive bone bruise is contralateral or big. The ipsilateral microavulsive injuries are small. And typical ACL bone bruises, everyone has seen this 100 times. And typical MCL bone bruises, and again, this is a contralateral compression. Sorry, this is a avulsion lateral. And bone bruises from patella dislocations don't necessarily mean there's a retinacular ligament injury or not. It's just, in this case, there is, but just bone bruises. Okay, now how about fractures? How are fractures different than bone bruises? Well, fractures, A, don't prognosticate long-term. They prognosticate short-term. So the major reason to look for a fracture is to explain a patient's lack of healing after a ligament. We stressed that ligaments heal well, right? So if someone comes in 2, 3, 4 weeks after a ligament injury and still has pain, it could be a bone bruise, unlikely, but could be. But also could be a fracture. So specific fractures you should look for: anterior process of calcaneus. You see that when you have a coalition and an ankle sprain. Base of fifth metatarsal, common in ankle sprains. High fibula, we all know Mays and New. And talus fractures, just because the prognosis, if missed, is very poor. And here is an occult fracture of the talus following a lateral ankle sprain. Okay, so we talked about the differences and similarities between tendons and ligaments. We spoke about where ligaments tear, mostly at the insertion, sometimes in the mid-body, particularly the cruciates, and infrequently avulse, unless you're a child and it's about the ankle. And then we spoke about bone bruises, how they give you long-term prognosis, help you identify the injury, and remember that compressive bone bruises are bigger than avulsive bone. But one thing we stressed is that ligaments heal pretty well. Let's talk about how they heal. The first stage of the injury is bleeding, is hemorrhage. And the cap of that hemorrhage will develop neovascularity, and that neovascularity leads to inflammation. In contradistinction to synovitis, which is bad inflammation about ligament injuries is good inflammation. It increases cell proliferation, which increases collagen and proteoglycan production. So that collagen will be self-organizing. Remember, we spoke about that. So the cells secrete collagen. The collagen on its own forms fibers, secretes proteoglycan. That proteoglycan brings in bound water, and then it will coalesce into what's called a neoligament, a new replacement ligament. And I'll show you many examples of this. And it remodels from the outside in. We spoke about this with anterior lateral ankle impingement yesterday. The problem with that impingement is it heals from the inside out, leading to convexity on the articular surface of the ligament. The collagen changes. We said it was 90% type 1 collagen, just like tendons. Remember? When a ligament heals, it becomes type 2 and type 5 collagen. And guess what? You think they're better than type 1 for what is there, or worse? Worse. So every time you sprain a ligament, the next sprain becomes easier, and that's why it gradually weakens when I showed you that. And it has less crosslinks. That also weakens. And rather than having elastin and lubricant, it gets by glycan and decorin. And the end result is a neoligament is about half the strength of the de novo ligament. So they heal, which is much better than tendons, but they still heal in a suboptimal way. When bone heals in an optimal way, right? A previously fractured bone that's healed has no risk of having a refraction more than any other bone. In fact, it probably has less. So it really, tendons and ligaments are really intrinsically different. So here's a patient who had an ankle sprain, and this is a neo ligament. And it's a very obvious one, right? This is way too thick. It has way too much internal signal. It has thickened and slightly abnormal morphology. Can you see that this is an abnormal ligament? This is what a neo ligament is. And neo ligaments form because you get a hemorrhage. So you see the hemorrhage? And that hemorrhage is the beginning of the neo ligament. So let's walk through that. So you'll get a hematoma, and that hematoma will eventually coalesce into a neoligament. And that neoligament tends to have convexity on the outer aspect, right? So here's a patient, they have a ligament there, and we see the blood from the ligament there, right? Now look closely about what's going to happen to that ligament over time. It's going to get smaller, but it's still going to keep the straight articular surface and this convex outer surface. But it's going to be thicker and have more internal signal than a normal ligament. I'll do that again. So you get the hematoma, and it then coalesces into a normal ligament. Now let me show you a bunch of examples of that. So here's a patient. This is the talus, this is the fibula, here the peroneus. Here's the anterior talar fibular ligament torn off of the talus, right? Not an osseous avulsion, a ligament avulsion. And now fluid violates that, and here's the rump of the ligament. Can you see the rump of the ligament? Now the ligament is beginning to reform. Do you see the neoligament reforming with a lot of signal inside of it and convexity posteriorly, superficially, and straight posteriorly? Can you see that? And now it keeps on reforming. It's getting darker and still has this relatively straight articular appearance. And then we have this neoligament, which is thick, has internal signal, but is basically where a ligament should be. And that's how a neoligament evolves, and it evolves starting with the hematoma. So as I stated, healed ligaments have this altered collagen. Right? They have type 3 and type 5 collagen. They have altered architecture. They have less crosslinks. Biochemically, they're different. they all result in a weaker ligament. Now, I showed you the prototypical healed ligament, which is a thick ligament, right? Okay. Right?
Yes.
But sometimes they can heal thin. And sometimes they can partially resorb. And sometimes they can completely resorb. So in the ankle, they typically heal thick. But sometimes they heal thick. The ACL, someone mentioned this yesterday, I think it was Muhammad, the empty notch sign. Because the proximal to the tear resorbs. Distal, you still see the stump. So the ACL proximally will resorb. When you tear your scapholunate ligament, you may see no ligament, right? It completely resorbs, and sometimes the same for the lunaris artery. So there's really 4 patterns of ligaments that we see. Now I'm going to say something that's going to blow your mind. And the pattern has nothing to do with stability. A thick ligament can be more unstable than a thin ligament. So the size has nothing to do with stability. Get that out of your mind, because if there's a lot of collagen and it's completely disorganized, it's not doing anything. It doesn't provide any strength. So it's comfortable to say a thick ligament is normal, but it more often than not isn't. And one surgical thing is called imbrication. Have you heard of imbrication? Can I borrow that?
Yep.
So in imbrication, they take a thick ligament and they fold it like an accordion like that, and then suture it up to try and make it more functional. It's not functional. A thin ligament can be functional, a thick ligament can be non-functional, but an absent ligament is never functional. So if your ACL is gone, it's never functional. Now there used to be a thing where you would have a dysfunctional ligament, and it wouldn't bother the patient. So let's say I'm very inactive. And I tear my ACL, and I get a routine need for a meniscal tear. And the radiologist says, "Hey, Schweitzer, you got an ACL tear there." And it's been there for a while. And I'll say, doesn't bother me, forget about it, just deal with my meniscus. Am I right or am I wrong? Should I leave the ACL? It doesn't bother me. My knee does not give out. I can do all my daily activities. My meniscus hurts, but my ACL is fine. What should you do? Treat the ACL, because you're going to get premature osteoarthritis whether it bothers you. So there used to be this theory of the stable but subclinical ACL. There's no such thing. When they do an exam under anesthesia, I'm going to be just as unstable as anyone else. I'm going to get just as much premature arthritis. So a thick or a thin ligament could be stable or unstable. An absent ligament is always unstable and is always going to lead to premature osteoarthritis. So here's a patient who had an old anterior tibiofibular ligament injury, and this is a relatively thin neoligament, may or may not be unstable. And so here's a patient with an atretic calcaneofibular ligament and a thick anterior tibiofibular ligament. Right? This patient was unstable. No, this patient was stable. This patient was unstable. I'll give you one more example. Thick and almost absent ligament, right? Stable, unstable. Now there are also chronically torn ligaments. And I don't like the term chronically torn. Better to say remote tears or repetitive tears. Because chronicity implies ongoing activity, right? I have chronic obstructive pulmonary disease. I don't have an episode, and then I'm good for a year, and then another episode. I have chronic hepatitis. My liver doesn't stop being inflamed for 6 months and then becomes inflamed again. Chronic diseases are continuous. Repetitive diseases are repetitive. So They use this term chronically torn. I believe it's a bad term. But we see this in diabetics. In fact, the index event in neuroarthropathy is a ligament tear. We see this in throwing athletes in the elbow. They get MCL tears from repetitive injury. Almost all scapholunate ligament tears are repetitive. Most Lisfranc tears are repetitive. Turf toe, which is a ligament injury, is repetitive. So there are repetitive ligament tears, even though most are acute. There are repetitive ligament tears. So here's an MCL tear with the T sign, and a scapholunate ligament tear, which is thickened, and another scapholunate ligament tear, which is avulsion off of the lunate. And we showed, I think, the same, different patient with an atretic anterior talar fibula. Now we said ligaments heal better than tendons, but they heal weaker, 50% weaker. And we talked about the tendons that resorb, and those that resorb have an association with instability. ACL, scapholunate, and lunatotrictal. So here's an ACL tear where we see the stump of the ACL, and we see the absence of the proximal ACL. And a patient with turf toe, they don't reconstitute their ligaments when they get a turf toe. It's completely. This is kind of an interesting case. So here is the anterior talar fibula ligament. Here it is here. And it's resorbed, right? You see the proximal portion, or the distal portion, I should say, is absent. Can you see that? The ligament ends right here. And even on the MR, which is not stressed, imagine what they look like. You see how unstable they are with articular curvature. So every ligament that's resorbed has some degree of instability, whether the patient knows it or not. Now, most ligaments heal at 50% of their strength. Some ligaments heal at less than 50% of their strength. And those that heal at less than 50% of their strength are really that have injured several times and have are on this downward spiral. And each time it's 50% weaker. So it's not as if they're intrinsically predisposed to healing poorer, they're intrinsically predisposed to repetitive injury. And we talked about anterior lateral ankle joint impingement yesterday, and this is ligaments healing okay mechanically, but suboptimal in terms of impingement. So that's all background for what ligaments are, what happens to them, and how they heal. But the problem with them is not usually the acute injury. The problem is the instability that results from the acute injury. So what does unstable mean? So the dictionary definition of unstable is lacking stability. Now, not a very useful definition. But it's the tendency of a joint to sublux or dislocate under normal activities of strength. And the key thing here is normal activities of strength. So subluxation and dislocation are the extremes. You have an energy vector of an extreme intensity, and then you dislocate. Instability happens way below the extreme. And the orthopedic surgeon I used to work with used to say, Mark, if you sprain your ankle every time you cross the street, you are unstable. If you sprain your ankle every time you play football, you have repetitive ankle. So the difference is the energy of the activity. Walking across the street is normal activities of daily living. That's a key concept. Now, what is micro instability compared to macro instability? Anyone know the difference between those? So micro is occult to the patient. The patient doesn't know there's anything wrong. So if you think about a spectrum, you'll have dislocation, instability, and then micro instability. And one theory behind micro instability is there's a positive to having micro instability. So if you look in the book of normal variance, you've all looked at the book of normal variance, maybe once, maybe 100 times. They have a picture of a slightly subluxed thumb where the base of the first metacarpal is slightly offset from the greater multangular or the trapezium, sorry. Yes? And that's really a hyper-opposable thumb. And they call it normal because certain people have a hyper-opposable thumb. And there are advantages to a hyper-opposable thumb, right? I can have a bigger palm and hold on to a bigger palm because that's hyper-opposable. So there's intrinsic advantages to that. But the more subluxation you have, the more likely you are to get basal osteoarthritis later. So that's, I think, the best definition of microinstability. It has a positive, and it makes you more functional, so it doesn't bother you, but it still predisposes to osteoarthritis. And this would be macro instability as opposed to micro instability. Sorry about that. So why is instability so bad? Because you develop premature osteoarthritis. And some people say, and I believe it, 50% of this disease is related to micro instability, as seen here on the flexion and extension radiogram. So we have a scapholuni ligament tear. You'll get what kind of arthritis from that? And the acronym is slap wrist, right? Yes. So about 3% of young adults per year present with shoulder instability. It's about 8% of all injuries, not just shoulder injuries, as opposed to ligament injuries, which are more common in women than men, like 3 times more common. Instability is equal in women or men, or in fact more common in women or men. And in the acute sense, so when we look at instability, we want to think of dynamic stabilizers and static stabilizers. Anyone ever heard those terms before, dynamic and static stabilizers? So when you examine someone under anesthesia, and they're unstable, but they were stable when you examine them in your office, they have a deficit of a dynamic stabilizer. So their muscles are all relaxed, and that brings up the instability that was masked because the dynamic stabilizer is involved. Static stabilizers refer to bones and ligaments. So I should say bones and cartilage, and then ligaments. So your shoulder has your glenoid, and if the glenoid was like this, you would be unstable. And if the glenoid is like that, you'd be very stable, right? So that's a static stabilizer. If I have a thick ligament, I'm very stable, a thick functional ligament, I should say. If I have a dysfunctional ligament, I'm less stable. Same exam under anesthesia, exam in my office for both of them. Static stabilizer. Dynamic stabilizers are always muscle tendons, and they would be the rotator cuff. So when you try and look at someone who has instability, you want to examine osteostatic stabilizers, ligamentous static stabilizers, and dynamic stabilizers. And an abnormality of any one of those will lead to instability. So we'll talk about that in a minute. We spoke about that. Okay. So most patients who dislocate will never become unstable. Most patients who are unstable have never dislocated, but the two are still related. So here's my yellow for dislocated. So most people who dislocate stay in this outer portion of the yellow. They never become unstable. Most people unstable have never dislocated, but there's a group of patients in the center. So what makes up this group of patients in the center? What about that dislocation makes them unstable? Injuries to the static stabilizers and the dynamic stabilizers that don't heal, that makes them unstable. And how could you be unstable if you've never dislocated? You had micro instability that gave you a functional advantage. You were never aware of it, and then you eventually become unstable. Kind of a key, very simple diagram to understand. So if you have a scapholunate ligament tear, you're going to get a slack wrist. Right? That's your arthritis. If you have an ACL tear, anyone know the pattern of arthritis with ACL tears? Patellofemoral greater than lateral femoral, greater than medial femoral. If you have posterior spine ligament injuries, what's going to be your sequelae, your degeneration? Disc, you get 50% of disc. Syndesmotic ligament injury is going to give you premature ankle arthritis. So they have a term for it that you appreciate here. If I say this in America, no one appreciates it. Football is ankle. Have you heard football is ankle? So in America, we play a different kind of football, so no one knows what it means. Football is ankle is soccer players who have chronic lateral instability get premature osteoarthritis. So 90% of soccer players will have osteoarthritis, I think, before age 35, professional soccer. That's called football is ankle. So certain ligament injuries predispose. Now, how about shoulder? Why is instability important in the shoulder outside the setting of the instability? Rotator cuff tear. So if you see a rotator cuff tear in a person less than 50, they're unstable until proven otherwise. So if you go in and you repair the cuff and you do a acromial decompression, they come back 5 years later with a recurrent cuff tear. Because the intrinsic problem was instability. The instability was never addressed. By doing the acromioplasty, all you're doing is unmasking that instability to happen again. So instability can lead to premature osteoarthritis, can lead also to rotator cuff tears, as well as meniscal tears. And just an example, so this is neuropathic joint. Do I have the wrong slide in this talk? Why do I put neuropathic Liz-Frank joint here? Neuropathic joints begin with a ligament injury. In this case, a Liz-Frank ligament injury. What makes their Liz-Frank ligament injury different than my Liz-Frank ligament injury? Because I have normal proprioception. I know I tore my Liz-Frank ligament, and I'm going to walk with a limp. And I'm walking with a limp to protect that ligament so it can heal. If I'm a diabetic and I have a Liz-Frank injury, I don't know I have that because I'm not neurologically attached. I go on walking my normal way. That ligament never get a chance to heal, to even get 50% of its strength. And I develop premature osteoarthritis. So that's why Liz-Frank neuropathic arthropathy is in fact a ligament instability. Okay, let's talk a little bit about pearls of dislocations. In general, dislocations occur in the opposite direction of where your vessels are. So again, I'll invoke God again. When He designed you, your dislocations occur in the opposite direction of causing vascular injury. So if you're going to dislocate, you're going to be less predisposed to vascular injury. So in the hip, your vessels lie anterior, right? So your dislocations are going to be posterior. In the ankle, your vessels lie predominantly medial. So your dislocations are going to be anterior lateral. In your elbow, your vessels lie anterior. Your dislocations are going to be posterior. Your sternoclavicular joint, your vessels lie, so your dislocation is going to be anterior. So when trying to remember the most common direction for, there's no exceptions to the rule, by the way. It works at every joint. So the most common direction for dislocation is always opposite where the vessels are. A incomplete dislocation is called a subluxation. In the spine, we use an alternative term, and that term is lesthesis. Very good. So why do we use an alternative term in the spine? Two reasons. When we have a dislocation, it's the distal aspect that determines how you call the direction. So a posterior shoulder dislocation, the humerus goes down. In the spine, it's the proximal one that determines the direction. So if C5 is in front of C6, that's an anterolisthesis. If the glenoid is in front of the humerus, that's a posterior dislocation. So it's the opposite nomenclature. The second reason is it's unusual, not rare, but unusual to have non-traumatic subluxation. It is the common to have non-traumatic listheses. Most listheses are degenerative. So that's pearls about dislocations. So here's an anterior dislocation of the shoulder, an anterior dislocation of the ankle, a retrolisthesis. Anyone know what this is? Luxatio erecta. And then a trough deformity from a posterior dislocation of the shoulder and posterior lateral rotatory instability of the elbow. Now you get some characteristic fractures in dislocations, right? We get characteristic bone bruises and ligament injuries, but dislocations give you characteristic fractures. And it's important to recognize those fractures because they predispose to instability, right? The static stabilizers become insufficient. So Hill-Sachs marks for dislocation predisposes to instability. Bankart predisposes to instability. In the elbow and the hip, you have the analog to a Hill-Sachs. Anyone know what that fracture is called? Pipkin fracture. And in the elbow, you get coronary process fractures and posterior capitalis. Now, the importance of that, again, to reiterate, is the static stabilizers are now no longer normal. So let's go back to microinstability, and then we're going to end with osteoarthritis. So athletes walk a fine line between having more or less stability, more motion than you or I, and having pathologic function. So if I'm a baseball pitcher, the farther I go back, the faster my pitch is going to be. If I'm a football player, American football, American soccer, and I'm a blocker, if my shoulders can go back, I can still continue blocking without failing. There's an intrinsic advantage to it. So microinstability is seen in almost every high-performance athlete because they're selected. It makes them better. And being better makes them do the activity more, which makes their microinstability worse, which gives them premature osteoarthritis, which is why you see hip replacements in so many professional athletes. So the effects of instability, whether it be micro or macro, are premature osteoarthritis. And there's a distinction between rapidly progressive osteoarthritis and premature osteoarthritis. You guys familiar with the term rapidly progressive osteoarthritis? So rapidly progressive osteoarthritis is in any time less than a year, so 363 days, I can see radiographic progression. So I have one X-ray in November of this year, and the previous X-ray was in December of last year, and I go, worsened osteoarthritis. If you can see changes in osteoarthritis in a year, that's termed rapidly progressive osteoarthritis. And rapidly progressive osteoarthritis is related to failure of osseous static stabilizers. There's only one cause of rapidly progressive osteoarthritis. So I have a joint, and my joint is a spoon on a spoon, right? When I get an insufficiency fracture, I get a knife on a spoon. If I get AVN, I get a knife on a spoon. And I get premature osteoarthritis. So premature, rapidly progressive osteoarthritis. So rapidly progressive osteoarthritis, osseous static stabilizer failure. Premature osteoarthritis, so rapidly progressive, means you see a change in less than a year. What is premature osteoarthritis? I'll give you a choice. 20 years before I should get it, 15 years before I should get it, 10 years before I should get it, or 5 years before I would normally get it. Who votes for 20? No one. 15. 10? 5? 10. The definition is 10 years. So if your mother had a knee replacement at 60 and you get it at 50, that would be premature osteoarthritis. Premature osteoarthritis is almost always instability, micro or macro, unless you have something like AVN or something, but most of the time it's related to instability, so think of a ligament injury. Now in general, 10% of ankle sprains become unstable. Now that's 10% of people who have ankle sprains, not 10% of ankle sprains. Because if it was 10% of ankle sprains, it would be 100% of people, right? Because most people, as I said yesterday, sprain their ankle any number of times through the year. So 10% of people who sprain their ankle will get instability. 3/4 of those will develop osteoarthritis, even within 10 years. That's a hell of a lot of people, if you think of it. And the osteoarthritis is focally anteriorly, and one of the presentations will be what we spoke about yesterday, anterior impingement. Now the other effect I mentioned is premature rotator cuff tear. So anyone who's less than 50 who has a rotator cuff tear, look at their labrum very carefully and overcall labral tear if in doubt. So this is the case that we saw yesterday, ankle instability with premature osteoarthritis. A patient with shoulder instability and premature rotator cuff. So what are the effects of instability? Well, you get less of a spoon on a spoon. Not because you have a spoon on a knife, but because one spoon is moving. So that's the static non-osseous stabilizer, predominantly. But then what will happen is it will start moving. And I have osteoarthritis in my left knee, and then osteoarthritis in my right hip, then osteoarthritis in my left sacroiliac joint, then degenerative changes in my spine. So one reason to address the osteoarthritis, just like you need to address the ACL tear, even if it's not causing symptoms for the patient, is because the knee may not bother them that much, but the hip is going to bother them. And by the time I would operate on the hip, they may be too old and may be a bad risk factor for hip replacement. Impingements are related to instability. So this primary impingement, which you're all familiar with, when I've been speaking about with premature rotator cuff tears, is secondary. Now let's concentrate on the dynamic stabilizers for a minute. I haven't really spoken about that. Any failure of a static stabilizer puts increased stress on a dynamic stabilizer. And in fact, when I said rotator cuff tears in patients less than 50 occur because of a failure of the static stabilizer leading to excessive stress on a dynamic stabilizer. And a dynamic stabilizer in the shoulder is the cuff. In the ankle, the dynamic stabilizer are the perineal tendons. And that's why perineal disorders are associated with ankle sprains. And that's why you'll get perineal subluxation, perineal dislocation, and perineal split syndrome. So here's a patient with a syndesmotic ligament injury and rapidly progressive osteoarthritis on MR. And this is just an example. How does this ligament look to you? Sure. Pretty good, right? Yes? Thicker, but not bad looking. Okay, maybe bad. But here's their stress right here. And I just want to reiterate the concept that a thick ligament can be unstable. This is unstable. Okay, so peroneal tendon disorders are of a high association with ankle instability because the static stabilizers have failed, and now the dynamic stabilizers get increased stress, and the dynamic stabilizers then fail. So you'll get peroneal dislocations from ankle sprains, peroneal splits from ankle sprains, stenosing tenosynovitis from ankles. So let's reiterate and review. Microanatomy. The collagen fibers are less parallel. They have the ability when stressed to become even less parallel. There are thicker crosslinks. Same type of collagen, but better blood supply because they're bathed usually on one side by synovial filters. Biomechanically, they protect you. They don't transfer force. Ligaments can sprain, grade 1, grade 2, grade 3, either at the avulsion, they can avulse from the bone, they can avulse a piece of bone, or somewhere in the center of the ligament. Bone bruises are more associated with ankle sprains than occult fractures, but occult fractures may be a reason why the patient comes to medical attention later on. Healing. They heal with a hematoma. That hematoma becomes a neoligament. From the outside in, that neoligament is 50% weaker than a native ligament. Instability is a result of either failure of a static stabilizer, and the static stabilizers can be bone or ligament, or a dynamic stabilizer. And the key dynamic stabilizers to think about are the rotator cuff and the peroneal tendon. Patients could also have microinstability, which is instability that they're not aware of, typically athletes, but the sequelae of dislocations, the sequelae of macroinstability, and the sequelae of microinstability is premature osteoarthritis, defined as osteoarthritis 10 years before that person would get it. If they have an osseous abnormality, they can also get rapidly progressive osteoarthritis, which is arthritis that progresses visibly within a year. Thank you for your attention.